it, there's so many things going on in VTE prevention right now that I think the fact that there's new drugs coming out, not every single day, but there's new oral anticoagulants for years and years and years and decades. We've really had injectables as the mainstay of VTE prevention for hospitalized patients. And now that we have more and more of these oral drugs, I think that is a huge bonus for patients. Most patients would rather be taking a pill than a shot. So whatever we can do and show that they're beneficial and show the science behind the benefits of these new oral drugs, I think is an important thing for us to be focusing on. The other thing I think is important is patient education and patient engagement in the field. I think when I started working on it 15 years ago, people didn't know about blood clots. It was not a common lexicon amongst the average patient. People knew a lot about breast cancer or other things, but we didn't really have a focus and a public health focus on DVT, PE. And I think that has changed over the past decade or so. There's more people interested in the question. There's more patients that are engaged and that are asking good questions and want to know what's the best thing that they can do. I think you have to understand what those are. And those are CMS giving and publicly reporting data on how we're doing for VTE prevention and treatment. So those have been out now for about a decade almost, about public reporting and measures for improving quality of care and measuring how we're doing at a hospital level for preventing venous thromboembolism. So there's VTEs 1 through 6. They've been switched over from the old manually abstracted to the electronically pulled ones. Those are the VTE-1 and VTE-2. I think those are important metrics. I personally have a pet peeve that VTE-6 is my personal favorite. We wrote about that before it came out and published a paper with Peter Pronovost in JAMA about that measure. That measure is, did we give appropriate prophylaxis to the patient before they had their VTE? And I think it really has a face validity, and that's my personal favorite of the ones you can go to the CMS website and look at. But I think the benefit of these VTE-1 and 2 are a wider population of patients that are important to look at. I still have a little concern about it looking at a small snapshot at the beginning of their hospitalization and not every single dose of prophylaxis during the whole course of hospitalization. So I think there's still some room to go. But I think anything that gets VTE prevention into the face of people in charge of quality and safety and into the public health sphere, I think is moving in the right direction. I think it's just the whole package. Every few years there are guidelines from different organizations about venous thromboembolism prevention on hospitalized patients. They used to be done by the ACCP, the American College of Chest Physicians. Now they've been taken over. Really, the most recent ones are by ASH, the American Society of Hematology. And I think they give kind of the most current up-to-date approaches to preventing venous thromboembolism in hospitalized patients. There's other guidelines as well, for example, in cancer patients in the NCCN guidelines. I think reading those guidelines about the specific drugs and who they should be for is very important. But I think it's also important to look at the overall approach and the general guidelines, maybe from AHRQ, Agency for Healthcare Research and Quality, that puts out documents about the approaches to venous thromboembolism prevention in general. How do we do risk assessment? How do we decide who's at higher or lower or moderate risk? And then once we know what those risk levels are, then how do we write the right orders for the right patients to help prevent blood clots in them? So I think there are these two pieces. One is the very nuanced piece of exactly which medication at which dose and which frequency. The other is the general approach of how do we improve quality overall in the VTE sphere. So I will tell you, there are very specific FDA approved reasons that rivaroxaban can be used. It really got into the VTE prevention arena with orthopedic hip and knee joint replacement surgery. So that's probably the one place that I see it personally being used the most. There's other studies now that are suggesting it for whether it be medically ill patients or for extended prophylaxis after other types of surgery. That it's being used and touted for many other arenas now. And I think it's important to know that patients would rather take a pill once a day most of the time than injecting themselves, especially as they're going home on these medications, sometimes for as long as, a month or 6 weeks. So I think that's where we are with rivaroxaban. I think more and more of these drugs, these novel oral anticoagulants, are going to be getting indications for other uses over time. That's kind of my, if I could look into a crystal ball, I think people are going to be looking for those, and we're going to be giving more and more of these medications both in the hospital as well as after discharge for the right patient population once we figure out who they are. Even just reading the lay press, everybody is starting to hear about COVID-19 and thrombosis. It's the microvascular thrombi. They think it's one of the main pathophysiologies of a respiratory failure. And then patients with COVID-19 are probably one of the highest risk patient populations for getting in hospital or hospital associated DVT and pulmonary embolism. So I think with that backdrop, people are trying to figure out what should we do to prevent that. So many organizations have come up with a pretty quick response guidelines and recommendations of what we should be doing for COVID patients. Should they all be screened more aggressively for DVT with ultrasound? Should they all be getting higher dose, double dose anticoagulation as an example that people are recommending? Should some very high risk patients be on full dose anticoagulation with either heparin drip or other approaches for prophylaxis, even if they are not known to have an event yet? So these are some of the great questions, and there really isn't any great scientific evidence yet. There's certainly not very large trials that show us what's beneficial in the COVID patient population. There's a few that are going on and being sponsored by NIH and others about trying to answer that question. I think the other thing that I'd be remiss if I didn't talk about was a question about diagnosis. So a lot of these patients with COVID-19, we know they're at very high risk for pulmonary embolism. So they're in the intensive care unit, they're on a ventilator, they're incredibly sick, hard to transport and get a CAT scan to rule in or rule out a PE. So a lot of these patients we think are being anticoagulated empirically before a diagnosis can be confirmed by radiology. And I think that's a really big change in people's clinical practice. Most of the time, the patients being suspected of having a PE in the ICU will be treated and then be getting a CAT scan either right after the diagnosis or the presumed diagnosis and therapy, or before the diagnosis is confirmed. I think that's really changing practice now, that people are getting a lot more presumptive anticoagulation and treatment, even without a confirmed VTE. So I think we will have to wait and see. We're going to get a lot more information. I'm a board member of the National Blood Clot Alliance, and we've gotten a grant from the CDC to work on this exact question of blood clots in patients with COVID. So you'll be seeing hopefully more information from that large multi-center study coming out over the next few months. I'll use this platform to suggest or talk about one of my own personal pet peeves. And it's a pet peeve, but it's supported with a little bit of evidence and a little bit of data. So we know that prescribing best practice prophylaxis is really important for patients. But we also know that even once this medication is prescribed, not every single dose gets administered to a patient while they're in the hospital. And we've done some work that shows about 12% of all doses don't make it to the patient. And one of the important reasons is patient refusal. And we think, at least in our studies that we've been able to show, there is benefit to engaging with nurses and educating them on the importance of VTE prophylaxis and teaching them of how to talk to patients about the importance of this VTE prophylaxis prevention. We can intervene and we can drop that missed dose rate by about half. So I think the interventions, not just to get the right medications ordered, but to engage with the patients and the bedside nurses to make sure that they're giving the right prophylaxis and the patients are accepting it is really important. And I think we are giving patient education bundles with paper handouts and videos explaining the importance of this to the patients, I think is a critical piece. So I think thanks for letting me rant about one of my personal pet projects. And in full disclosure, we've got a lot of that work that's funded by PCORI, the Patient-Centered Outcomes Research Institute. So I want to make sure everyone knows that piece as well.